Hi, I'm Molly, the student nurse. Can I have you state your name and date of birth? Good. All right, and so we're going to be doing a respiratory assessment today. I'm going to ask you some questions, do some palpation, and then listen to breath sounds. Do you have any questions before we get started? Okay, so before we get started, I ask the patient, do you have any history of respiratory symptoms or any respiratory issues such as asthma, bronchitis, COPD, emphysema, pneumonia? So I ask about the history of respiratory, and I'll ask family history of any of those conditions. Then I would ask, what do you do for a living? So she works in an office. And the reason I ask what a person does for a living is certain occupations have lung irritants that can be toxic, can irritate the lung and cause problems over time, such as farmers, foundry work, hairdressers even. So it's good to ask if they're around those toxins that could be irritating the lung. Then I ask about lifestyle. So do you smoke? I would ask about diet. Are you eating a well-balanced diet, or are you maybe heavy on the bad foods or saturated fat and salt? Or are you more well-balanced diet? So what's a normal meal for you? And I also ask about activity level. So she did say she works in an office, which is kind of a more sedentary job. So I would ask, do you exercise regularly then? Can we talk about that? I also ask about medications. So do you use inhalers or nebulizers? Do you take things like steroids? What about maybe opioids, because they lower your respiration? So it's good to ask about medications. At this point then, we are ready to inspect. So I would start with the symmetry. I would feel, asking permission first, hands are clean. I'm feeling symmetry. If one side were to be lower, that could be indicative of a pneumothorax or a collapsed lung. So we're feeling symmetrical. I also look at things, if they're barrel chested, that is indicative of COPD. I would look at the fingers. So this gap would not be here with clubbed fingernails, and that is from acrotic hypoxia, so long time not getting enough oxygen. And I would look, are the nares flaring, so nasal flaring, pursed lip breathing, things like that. I also just do a general appearance of the person. So I'm looking at skin, huge. Is there a lack of color, which is called pallor, or a bluish hue, cyanosis, meaning oxygen isn't getting there? I look in the mucous membranes as well. Feeling, is it warm and dry? Do I have capillary refill? Is my patient anxious? What's their level of consciousness? Are they using accessory muscles to compensate, help the breathing? Are they leaning over a table to breathe? All things I would look at for general appearance. So then we're ready to palpate. I'm going to start by looking at excursion, which is feeling that the lung expands and contracts. So we turn the patient around, and at the 10th intercostal space, I would count, I would find it, put the thumbs, and with inspiration, I want the thumbs to come apart 1 to 2 centimeters, and on expiration, come back together, showing that the lungs expand and contract. So do that, and then I also feel for a vibration called tactile fremitus, and I would feel 99, 99, have the patient say 99, 99. So I'm feeling. So if I'm feeling an increase in vibration, that could mean consolidation like pneumonia, maybe even a tumor. If I were to feel lowered vibration, that would be lower density. That could mean pneumothorax, or so pneumothorax, I believe, or emphysema. And then with an absence or no vibration at all, could mean severe asthma or emphysema or COPD. Okay, so I also am going to percuss. With percussion, we're listening for the amount of air in the lung. So how that works is we place the hand flat and we just tap and we're listening. So I'm going to the front as well. So if we were to hear resonance is normal, there should be some air, it is a lung. Hyperresonance could mean an overinflated lung, and then that could be pneumothorax. And then if we heard a dull sound, that could mean fluid, so pneumonia, maybe even left-sided heart failure, you would have fluid. And then flat could mean a tumor. So all things we look at. And then I'm ready to, I percuss, so I'm going to auscultate. So I would listen on the front and back, having the patient, before that I would also, before auscultation, I would count the respirations. 12 to 20 is normal, and sometimes the patient they change it because they know you're listening or you're counting. So sometimes you can feel for their pulse while you're, they think you're checking their pulse, but you're checking respiratory rate, rhythm, depth. So rate, like I said, 12 to 20. Depth, are they going shallow or are they going real deep? So just a nice depth. And then rhythm, is a normal rhythm or is it changing up? So that I'd also look at. So in auscultation, I would instruct the patient, inhale through your nose, exhale through your mouth. So let's go ahead and auscultate. And I'll be listening. There's normal and abnormal sounds, which I'll go through in a minute. So I'd be inhaling and exhaling here. Okay, good. So normal sounds, let's just flip her around here. So bronchial near the throat here is dull, a low dull sound. It has a shorter inspiration and a longer expiration. Bronchovesicular in the center here would be equal length inspiration and expiration, and then vesicular would be a longer inspiration and a shorter expiration. There's also abnormal sounds. So first there's crackles. So crackles, it sounds like rustling leaves, mean there's fluid there. That could be pneumonia, left-sided heart failure. We could also have rhonchi, which is a snoring sound, and that could be indicative of COPD. Could also have rhonchi, crackles, wheezing, a high-pitched musical sound. Wheezing, there is an obstruction, but it's usually due to inflammation narrowing that airway. So things like asthma. Pleural rub could be from an abscess or pleurisy, and it's a grating sound. You could also hear stridor. Stridor, to me, stridor would be like a gasping, a kind of grasping to catch that air. So maybe more emergent, hearing that. We could have absent sounds, so then we need to act fast or something going on where there is no sound. We could have, and then we also check bronchophony. So with bronchophony, I have the patient again say that 99. If it's muffled, that's a good thing, but if I'm hearing it very clearly, there could be consolidation then. So things like pneumonia. And then also egophony, which is the patient goes E, 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 and if I'm hearing A, there could be consolidation, so things like pneumonia. And that completes the assessment.